All right. Well, thank you all so much for joining us. I would like to introduce Dr. Nora Bucher. Dr. Bucher is a board-certified medical oncologist and hematologist. In addition to over 20 years of clinical experience, Dr. Bucher has subspecialty training in breast cancer, cancer genetics and genomics, and pharmacology. She treats all types of cancer, but does have a special interest in breast cancer, lung cancer, melanoma, and hematologic malignancies. And when she's not working, Dr. Bucher loves to travel, cook, watch comedies, and spend time with her husband, 2 children, and 2 dogs. So we're so happy that you're here with us, and please take it away.
Thank you so much. And thank you for coming this evening. My slides are not, I don't have too many, and this isn't too long, but I want it to generate discussion, hopefully, and questions. So I'm going to share my screen and hope that that works.
Here we go.
Thank you.
No problem.
Okay, so that's the title of our talk, Metastatic Breast Cancer Genomics Using Liquid Biopsy to Help Guide Treatment. And then I thought some objectives would be to learn about the genomics and metastatic breast cancer, which a lot of this, I think you all know, but I just wanted to get into really the liquid biopsy because I think that's a newer thing that we've been doing. But understand liquid biopsy and then maybe to learn some treatment sequencing strategies. Next slide. Or the other way. So I think we all know that, oh dear, this is my old presentation. Give me one sec. Well, I'll just fill in what's missing. So, and I'll send in the more updated slide deck. But basically, I think we all know that the basics that we glean from pathology, and we need tissue for it, as the estrogen receptor, progesterone receptor, HER2 expression, the proliferation index, either known as the Ki-67 or the MIB, and then grade, and then something else that we need from tissue that's pertinent in metastatic triple negative breast cancer is the PD-L1 status. We need tissue for that. But nowadays we can also use liquid biopsy to help us find different mutations that we use to target our therapies. You can go to the next slide. This is just a general schematic of, and I thought I'd use the example of hormone receptor positive advanced breast cancer. I don't know the breakdown in the audience in terms of HER2 positive or triple negative or hormone receptor positive advanced breast cancer, but I'm going to get to all of that. But I like the schematic. This was courtesy of the oncologist. I had the reference in my new slide. I apologize. But basically kind of showing this, it's a complicated diagram, but it kind of goes through where different medications take effect in the cell cycle pathway. And so many of you probably have heard of palbociclib, ribociclib, or abemaciclib, which we refer to as CDK4/6 inhibitors. And nowadays you can see that in the center, and that's the pathway that's followed. We often don't have to test tumor tissue for any sort of particular mutation to use these medications. Same with if you go to the right, our aromatase inhibitors, we usually don't have to test tumor mutations, nor for fulvestrant. But a newer drug that's out in the world now is called elacestrant. If we follow clockwise around this diagram, it's also known as Orserdu. And that is really one of the focuses of this talk, is that this is a newer drug, and it is approved for patients whose tumors have ESR1 mutations, and those are mutations in the estrogen receptor. And a liquid biopsy can really be very effective in obtaining that mutation. So I'm going to get to that a little bit later. Then you can see as we continue around the kind of the circle, you see tamoxifen showing up there. We don't normally test for mutations for that. But then as we go around, and nor for everolimus or Afinitor, but up at the top left, we have alpelisib, or also known as Piqray. The PI3K mutation, that pathway, as you can see, kind of going down with PI3K, AKT, mTOR, is a pathway that is inhibited by this medication. And that PI3K mutation is definitely something that we want to know about. And we can obtain that from liquid biopsy as well as tissue. And same for the ESR1 mutation. I think it was just last week, or maybe it was 2 weeks ago, the FDA approved another medication that is part of this pathway. It's called capivasertib. I am blanking on the trade name of it right now, but it should be available any minute now, as the FDA has approved it. And it's actually thought to be better tolerated than alpelisib. And I'm not sure if anybody in the audience has had that medication or knows of it. It can be tough to tolerate. And so it's pretty exciting. We have a new medication that we can use to target that pathway. And therefore that finding that mutation is very important. We can advance the slide, please. So this is just a listing. This is from the NCCN guidelines, which is the National Comprehensive Cancer Network, which is what we follow for diagnosing and treating. And it's something that, insurers go off of. And many of you have probably heard of these guidelines, as they offer patient guidelines as well. But you can see on the left side, sort of in her hormone receptor positive, HER2 negative, and then any metastatic breast cancer. These are some of the mutations that are important in targeting treatments. So you see up at the top, the PIK3CA activating mutation, and then to the right, the FDA approved agents. And as we go down the pathway, you see the ESR mutation, and then elacestrant, and then NTRK is another fusion. I've seen it one time, but there is it's potentially in all cancers, and so there are medications to target that. Then we also have something known as MSI high or MSIH, which is microsatellite instability, and that has to do with kind of the gene expression, and it indicates that a patient may respond to immunotherapy such as pembrolizumab or Keytruda. And some other immunotherapy agents as listed. And then also something that's important, and we can glean that from liquid biopsy, is the tumor mutational burden. Greater than 10 mutations per megabyte, I guess, we can also use pembrolizumab. And then there's also the RET fusion, which there is a targeted therapy for that. So also, if you advance the next slide, please. These are some of the other emerging mutations and targeted agents. And actually not really emerging is getting, if you have a germline BRCA mutation and even a PALB2 mutation, you could be a candidate for the PARP inhibitors. One example is olaparib. Also, we can find these mutations, in the germline, and we test with a blood test. It's kind of separate from this discussion of tumor mutations, or what I'm, the liquid biopsy, but we can also find these mutations in tumor tissue. And so that can also be found via liquid biopsy. So we can find it in the blood and then also in the tumor cells via liquid biopsy. Next slide, please. So the advantages of liquid biopsy versus tissue are that we can obtain circulating tumor cells and tumor DNA, which we also can glean from a tissue biopsy, but often a tissue biopsy can be difficult and painful. And if we're trying to obtain an ESR1 mutation, what's interesting about that mutation is that can be acquired over time as the cancer sees more treatment. So at initial diagnosis of metastatic hormone receptor positive breast cancer, we may not find the ESR1 mutation, but then in time, it can develop. Some of the statistics say that about 5% are found at diagnosis, and then up to 40% can be found as we continue to test a patient. So what I like to do is to test my patients at each progression with a liquid biopsy, rather than having to do another tissue biopsy, or if there's a new metastatic focus, putting someone through another biopsy doesn't necessarily make sense. Just from practicality standpoint. Next slide, please. Oh, I'm sorry. Could you go back to that slide? The other thing I wanted to mention, that you may have heard of some of these companies that perform the liquid biopsy, such as Guardant or Foundation Medicine. There's also this notion of using circulating tumor cells to capture if there's minimal residual disease. For example, in some patients who have early breast cancer, this might be a way to monitor if there is a recurrence. And I was talking with a company called Natera about their product, and they do report that sometimes a patient we can find minimal residual disease in circulating tumor cells and not see anything on imaging, but about 20% of the time we'll find something on imaging. So that's kind of an exciting thing to do, to maybe catch an early recurrence. And then also I mentioned the cancer diagnosis, there's that company Grail that is using circulating tumor cells to determine if someone has developed cancer. It's a little bit early in the game, and it kind of fraught with, I know you can buy the test and do that. It's a little bit difficult when there isn't an actionable kind of tumor to treat. But these are some examples of how we're monitoring circulating tumor cells. These came out, this notion is not new, and it came out years ago. And I remember about 10 years ago using circulating tumor cells as a way to monitor response to treatment, like meaning if you had a lot of circulating tumor cells and then you have treatment and they go down, that's a way to monitor. And I found that at least back then, those tests were not as helpful, because I could see a patient with many metastatic foci and her tumor cells were 0, and the converse could be true. So we're needing still a little bit more work in that field in terms of using it in that regard. Next slide, please. So what is a circulating tumor cell and the DNA? What does this mean exactly? As you can see from the drawing, the breast tissue, cancer cells get into the bloodstream and they shed their DNA, and that can be captured in the bloodstream. And you can see circulating tumor cells coming from bone or from visceral organs. And then we capture that with a liquid biopsy. And in particular, we can use this for the ESR1 testing, but also for all those other biomarkers that I mentioned earlier. Next slide, please. And again, what's interesting, because oftentimes when I've given a lecture, I've talked about elacestrant to other providers, and when this always comes up about liquid biopsy, oh, tissue's got to be better. And in some regards, it is more sensitive. It's sometimes difficult to get all the tumor in a liquid biopsy. But what's nice is you can capture the tumor heterogeneity. It's less invasive. And it can be faster. Usually the turnaround time is like a week to 10 days versus with a tissue biopsy, it can take up to 30 days. That's on the longer side. And then the other concern is that old tissue, which we want to access, sometimes doesn't provide an adequate sample for accurate biomarker testing. So hence the push for liquid biopsy. Next slide, please. Excuse me. So this is just a sample report. This was from Guardant. And I don't know if any of you have seen one of these reports before, but I just use this as an example because it's a very busy tumor that this patient had. But you can see that all the PIK3CA mutations, I know it's a little bit hard to read, but then the report gives you these associated therapies that we can use. And then you can see also this patient had BRCA1 and an ATM. ATM is another thing that's emerging, and RAD51D. These are all kind of previously thought to be germline mutations, but we're also finding them in tumors. And so that you could see that would lead a patient to maybe get a PARP inhibitor like olaparib. But that, I just wanted to show an example of that. And then it kind of also gives you the percentage of the circulating tumor cell DNA that is captured. And it also provides, if there are clinical trials in the country that would be relevant, and it's a helpful report. Next slide, please. So one of the things, just to change gears, and I hope I haven't lost everybody, but I know we'll have questions at the end. Just in thinking and kind of going back, this is in the hormone receptor positive breast cancer patient. And going back to that diagram I showed earlier where we kind of followed it around the circle, I think, and I don't want to belabor all of this because some of us may not be on this line of treatment, and some of us may. So, but usually the first line treatment, the oncologist will choose either an aromatase inhibitor or tamoxifen and ovarian suppression, or fulvestrant plus one of those CDK4/6 inhibitors, such as Ibrance or Kisqali or Verzenio. And then in the second line, depending on what a patient received in the first line, you may switch out the aromatase inhibitor or the fulvestrant. You may put in everolimus, which is Afinitor, or you may, if there's that PIK3CA mutation, you may want to use the alpelisib or the capivasertib. That's that pathway, versus elacestrant if there's an ESR1 mutation. And then as you go to the next line, you see that kind of the treatment options open up and change depending on what one has received before. And then by the fourth line, usually a patient has had some sort of chemo, and then what is required for a newer drug, and you may have heard of TDXD and HER2 or trastuzumab deruxtecan, that is approved in patients after they've had one line of chemo. I know I was excited to use it when it was first approved, and I was able to get it approved without a prior chemo line, but that's a very good drug. And then and you can see as we go down the line, then it opens up to sacituzumab govitecan or Trodelvy. That's another option in this sequence. And then, these are other considerations in terms of where would treatment go. If a patient had the TMB high, again, that would indicate some immunotherapy, as well as the MSI high indicates immunotherapy. And again, with the BRCA and the PALB2 and the other mutations that are in that family, we can use those PARP inhibitors. And again, the rare mutations such as and we call it NTRK or the RET mutation, those have their own targets. Next slide, please. So I kind of didn't focus a lot on HER2 in this discussion because HER2 we haven't identified a lot of mutations in the tumor cells that can be targeted. We target the HER2 overexpression, and that is a very important target, but we don't have a lot of use in this subset of breast cancer patients for a lot of tissue biopsies and liquid biopsies to look for mutations other than those kind of global mutations such as the TMB or the MSI high or the BRCA mutations that are kind of not necessarily related to hormone receptor positive breast cancer. So then, oh, I'm sorry, do you mind going back a slide? Okay, yeah, then go forward one. Okay, so with sequencing HER2 positive breast cancer, as you know, we often use TPH, which is Taxotere, Perjeta, and Herceptin versus endocrine therapy plus Herceptin in the first line. And then the second line, depending on what a patient has received before, we kind of progress down the lines of therapy. And you can see that TDXD coming up again. In the third line, things open up quite a bit. There are a lot of different treatment options. And again, we don't need to test on each progression with liquid biopsy in this subset of breast cancer patients, at least not right now, where, the field is evolving and we're often looking at new targets and new biomarkers. But for now, HER2 is pretty straight. HER2 positive breast cancer is somewhat straightforward. And then you can see, just as we go down the line, tucatinib enters the scene, which is a very good drug, especially for brain metastases. And then margetuximab is another drug that we use down the line, and neratinib, and these are all just excellent choices. And so again, in a HER2 positive breast cancer patient who maybe has seen all of these treatments, again, we could turn to our molecular testing to look at whether or not immunotherapy would be indicated, or a PARP inhibitor. We would probably know the BRCA mutation status at the beginning of treatment, and we would be able to plug that in accordingly. Next slide, please. And then for triple negative breast cancer, it's tough because unlike hormone receptor positive that has a target and HER2 that has a target, we don't for triple negative breast cancer. So we do really rely on tumor genomics for helping with our treatment decisions. And in the first line, this is where we want PD-L1. And unfortunately, I haven't found a liquid biopsy that test this accurately. So this needs to come from tissue, but that would probably come from the initial biopsy proving metastatic cancer, and we could get the PD-L1 expression from that. And so if that's positive within a certain amount of positivity, and there are ranges that we use, a patient can receive chemotherapy plus the checkpoint inhibitor pembrolizumab. If the tumor is PD-L1 negative, then often just chemotherapy is recommended. And certainly this is where, if a germline BRCA mutation or a PALB2 mutation is found, this is where we could use a PARP inhibitor or even a platinum drug. And then when we get into the second line, things open up a bit more. Again, we can use PARP inhibitors. Might want to use immunotherapy just if there's TMB high, regardless of the PD-L1 status, although usually those two go hand in hand, but not always. This is where sacituzumab govitecan or Trodelvy can come into play, as long as a patient maybe had two lines of therapy, at least one in the metastatic setting, and then one could have been in the adjuvant setting, kind of with, I believe, in the adjuvant neo or adjuvant setting, and then one in the metastatic setting. And then this is also an interesting space where trastuzumab deruxtecan or HER2 can come into play, because it has efficacy in triple negative breast cancer, or HER2 low, which often can be hormone receptor negative. And then also we have our single agent chemotherapy that we use. And then going down to the third line, again, utilizing the genomics of the tumor, and we can offer PARP inhibitors or immunotherapy, or the NTRK inhibitor, again, Trodelvy or TDXD or other chemotherapy. And there may be another antibody drug conjugate coming into play. I'm not sure if this year, but it's being studied pretty closely. So I just went to San Antonio, and there unfortunately weren't any new drugs for metastatic triple negative breast cancer that kind of are going to change practice. I do want to mention, just since I'm bringing up San Antonio, that there was a drug, Dato-DXd. This is another antibody drug conjugate that showed promising efficacy for HER2 low breast cancer. So that's a new drug. I don't know when the FDA will approve it, but that did come out of San Antonio. And I want to put a plug in for our review of San Antonio. I know that Compass up in Vancouver often does that program. We also offer it in Portland, but to go to a Best of San Antonio review is coming up. Next slide, please. So this is where I had my thank you and my email, and I'm sorry I didn't get you my my edited slides over, but I will make sure that those get sent to to everybody. And that's the end. And I hope there are questions and confusion. I hope not, but.
Thank you so much. And I can edit out that part too. So no worries about the change of the slides. So I will stop the recording real quick. Thank you so much.